Good morning, everyone, and welcome to our second panel discussion of today's summit, and it will be titled, The State of Advocacy and Access and Care in Canada. My name is Ika Washington, and I'm delighted to moderate this important discussion and conversation today. Today we will be examining the evolving landscape of rare disease policy and access within Canada, a space where progress is often hard-won and also deeply personal. In Canada, advocacy for the disease, amyloidosis, has resulted in improved access to certain treatments and the development of national research infrastructure. But there have been significant challenges that continue to remain, especially around the concern of timely diagnosis and equitable access to novel and high-cost therapies across all provinces and territories. There's a recognized need for real-world data to inform clinical decisions and also resource allocations. Today's panel will be discussing aspects of the need for coordinated national rare disease strategies, the ensuring timely and equitable access for high-cost therapies, looking at improving diagnosis pathways as well as physician education, looking at supporting data collection as well as real-world evidence, and also looking at how do we enhance patient and caregiving support as a bridge to the last panel discussion. Today we're joined by our esteemed panel, which is also George Smitherman, Carrie Altrin, and also Stephen, what's your last name, Stephen? Merritt, thank you, Stephen. And they'll be able to share their expertise as well as their backgrounds and lived experiences within the space of rare disease. So without further ado, I will go into our actual flow of our panel discussion to really set the scene around the state of policy. And if you don't mind, I will be sitting just because I'm in a little bit of pain today as well. But so I'll just coming over here and I'll just start with our first conversation and question today. So today I'd like to really ask and each of you to kind of reflect, to also describe who you are before you answer, but also looking at how do we reflect on the current state of rare disease in terms of policy within Canada? And all of you, I'm going to ask you this question for all of the answers, but with some follow-up as well. So how would you describe where we are today and what the momentum is? Where is there a lack thereof in terms of where you're observing in this space of rare disease?
Thank you. What a gentleman. Thank you so much. This is a real privilege to be part of this panel and to be speaking today. And I'm really happy that this panel goes after the first panel so that we're going to kind of take it up a level and really talk about it from a rare disease policy perspective. But it was really great to hear some of the real stories and personal experiences of the first panel, which I don't think are really surprising, because I think in the broader sort of rare disease discussion, these are really common themes that keep coming up, particularly around access to specialists, basic access to primary care being a huge barrier. But I'm gonna answer your question. So again, hi everyone, I'm Carrie. I work at 360 Public Affairs. We do a lot of policy work in the rare disease space. And I'm an epidemiologist by background, and I actually focus more on cancer epidemiology, and I started my career at Cancer Care Ontario. So I'm going to kind of draw some parallels between the cancer system and the lack of a rare disease system in Canada. So you'll hear me kind of go back to that a little bit today. Okay, so rare disease policy in Canada. My first thought is fragmented. We have definitely made a lot of progress in the past 5 years, which I'm sure we'll get into throughout the course of this discussion. We do have a national strategy for drugs for rare disease that was announced in 2023, which is fantastic. There was $1.5 billion, which is not a small amount of money, allocated as part of this national strategy for drugs for rare disease, $1.4 billion of which went to the provinces, which all of you know is where the healthcare system is really implemented, and that's where the health systems are. It's in the province, it's in the jurisdictions. It's not a national, one Canadian healthcare system, it's multiple. So I think that's kind of where the fragmentation really begins. Every province has the ability to do something different with this amazing amount of funding that's on the table. And there really is a lack of transparency in terms of what is being done within each of the jurisdictions. We know that there is a common list of drugs for rare disease that the provinces are responsible for funding from that common list. However, there's also funding that's allocated to things like screening and diagnostics, and we really don't have a good sense right now in terms of what is being done at the provincial and territorial level. So I think, fragmented is where my mind goes in reaction to that question. I think that also holds true for data collection and registries for different rare diseases. I think that each rare disease might have pockets of registries and data available, but there's no sort of overarching strategy for this, and it's a very fragmented system. And maybe I'll stop there. I could go on, but I'm gonna stop there and turn it over to my other panelists.
Good morning, everybody. My name is Steve Parrott, and I have two daughters with VHL, von Hippel-Lindau, which is a rare disease. It's hereditary. And so they've had quite a journey that I think mirrors many of yours. And there's a lot to be done. I think I agree with Carrie as far as the fragmentation. And so this type of conference is so important to bring us together and really bring the energy that's needed to progress in the advocacy world. So I'd really like to thank Anne-Marie for inviting us and inviting me to speak. As far as the national strategy money goes, it's very important that we take this opportunity to make sure that the money is well spent. It's a 3-year program. We're halfway through it now. The money's already been distributed in year 1. But, Quebec signed on, I think, 3 days before the year end. So it's going to be very interesting to see where the money went. The group that I'm with right now is called the Pan-Provincial Rare Disease Action Group. And it's part of the Canadian Rare Disease Network. So we're a bunch of advocates and patients and caregivers that are trying to work to get more transparency at the provincial level. We're based on a recommendation from Gail Willette, who's running the RQMO. And I don't know, is there anybody here from Quebec?
Oh, there's a few. 1,
2, okay.
Wow, a few people.
So you've got the RQMO working for you out there, and it's a great organization, and Gail has taken that concept to an organization called the iRare Centers. And I talk about it so much that I think Anne-Marie thought I was part of it, but I am not. I really respect the organization, and I talk about it a lot because it could be a real linchpin for supporting all rare diseases across Canada. They have a 1-800 number and an email that is very responsive, and they will point to 200 rare disease organizations. So I could talk about that all day. So that's the only thing I'm going to add, just from a fragmentation perspective, is that the rare disease money allows 10% of each provincial fund, all the money that comes out of the national strategy, 10% of it going to each province could be used for screening and diagnosis. And I think that's a real opportunity for us as advocates to get together and push the provincial governments to spend that money wisely. And I'll pass it over to George.
Thank you. Is this on? Is this thing on? Hi, I'm George Smitherman. I am a person that spent more than 40 years in and around politics and government at all levels. That included a stint for 5 years as the Minister of Health in the province of Ontario from 2003 until 2008. I think, just to pick up on the word fragmentation, I think, one of the things that frustrates me the most about our country in the conversation of healthcare is that, and I think the media frankly does this frequently, is that there's a lot of people that don't actually understand that while it's a national value, and while the Canada Health Act is important, and while there are substantial transfers to the provinces from the federal government, it is not a Canadian healthcare system. And I think a lot of Canadians don't frankly understand that. I'll just give you an example. The other day there was a story that ran at the top of the news cycle about a new promising drug to slow down the advances of Alzheimer's. You saw it.
Yeah.
You saw it. To me, it was a ridiculous story. I hate to say it so directly, but I'm direct. That story was built on this conveyance that there's a national healthcare system, and accordingly, since there was Canadian government approval from the regulator, goodness gracious, that should end up on a list. As the Minister of Health in Ontario, I would frequently get told, oh, Health Canada approved X or Y, and I would say, oh, did they fund it? And I think that, sadly, there's quite a disconnect on these matters in Canada. That advance on Alzheimer's was presented with a lot of hopefulness to people that are struggling or suffering from that, and we know that's very prevalent and the prevalence is growing. But I thought it was really disingenuous to all of those people for it failed to frame the reality context, which is that approval doesn't necessarily mean that there's an efficaciousness from a cost standpoint, which is a consideration in a single-payer healthcare system. So I think that the fragmentation to a certain extent that's spoken about and is very real is the reality that you're operating in, but also I would say to put a circle around it as the opportunity. And one of the things that I tell people constantly in trying to make them understand the way government works, to the extent that I figured it out, is that everybody loves a precedent. And there is an opportunity in that fragmented world to make a breakthrough in one province on an advocacy matter related to diagnosis or covering drugs that others will sometimes follow along on. I think that also with respect to fragmentation, it is in the area, I would say, of drug approvals that the provinces and the national government are more aligned. And I think this is a hopeful sign also. I really do understand that the challenges of trying to get great big departments in really large governments to pay a sufficient attention to something that's rare and therefore obviously not affecting that many folks is a massive undertaking. And like full credit to Anne Marie and to all of the energy that's brought together around this. But I think that finding common cause with other rare diseases is a really, really critical piece of the prospect for progress. And then just to throw one or two more. I always have more. Ika knows me well, so she'll just elbow me in the ribs. But I think that there is a lot of evidence that we have this fragmented system that's been spoken about, but I don't think there's enough clarity or honesty to say that the structures that we have to run these massive healthcare systems are not big enough. They're not, big isn't the right word, I suppose. They're actually not very sophisticated to pick up the signals that aren't hammering many, many people. So I'm just saying, like, you're in a difficult spot, but you're doing the work necessary to try and advance things. And I'm a hopeful and optimistic person. I think the rare disease strategy, the funding that came from the national government, comes with a real challenge too. The national government does not do anything to hold the provincial governments accountable to spend the money where they're supposed to spend it. And I don't think that's going to get better in the current austerity environment from the national government, because they're in a balancing act with the provinces constantly and actually kind of letting them do their own thing, not holding them accountable to the tremendous expansion of two-tier primary care, which is certainly very alive in Toronto and probably in other places. So I think this is part of the challenge that we have. I was part of the health accord spending from the Paul Martin government, influenced by Romano. Ontario got a very significant allocation. We went and spent that money in the 4 areas, like, earnestly. And actually, retrospectively, I see that many other provinces didn't do so. So a few comments for me to get started, and look forward to the next questions.
Yeah, absolutely. And thank you all for your insights. And I guess I wanted to turn to Carrie. Moving towards, we talked about the increase of funding and the opportunities and the allocation, but in your Coles notes, very simply, from your perspective, working closely on government relations, how has rare disease evolved within the past 5 years? And Stephen really hit on it in terms of the funding allocation, but in other areas, has policy actually evolved much, or has it been slow? What does that look like for people who may not be following the news all the time?
So I think, in the past, I'm hopeful, and this is promising progress. Like, I think we've all sort of touched on the fact that there is a national strategy for rare disease that was announced in 2023, which actually happened after Quebec. I think Quebec was 2022, I believe, that it launched its rare disease policy. So, by the way, that remains the only province in Canada that has a rare disease policy. So kudos Quebec, and Ontario maybe can, demonstrate some leadership and follow suit. But, I think that's really good news, right? Like, I think that is tremendous progress, and it's the work of everyone in this room, and we talked about this a little bit before this panel, but the role of patient organizations and the patient communities within the rare disease space are so incredibly powerful and strong in Canada. It's remarkable, and that is the result of all of you and all the different rare disease organizations advocating every day tirelessly to make this happen. So I think we should all be extremely hopeful, given the fact that there is now government recognition that rare disease deserves attention and deserves funding and support. So without policy, I mean, you don't really have the support to get too much done. You can have medical advancements, research and development. There's incredible stuff happening on sort of the science and medical side. As you can see, like, there are therapies now online for amyloidosis and other rare disease, gene, cell therapies, curative in some cases for certain rare diseases. That is incredible. That's incredibly promising. And I think, policy is a little bit slower. It doesn't necessarily keep pace with the innovation. And I think we all sort of recognize that is the case. But these are really good signals that there is at least recognition of rare disease and the importance of rare disease. Because at a population level, at an individual level, it might be rare, but at a population level, it is 1 in 10 people in Canada that are affected. So it has a huge impact in Canada. And I wanted to build on a point around rare being a challenge. It is a challenging situation because you kind of hear the word rare and you think, okay, this is a small population size. Governments are responsible for the entire country or the entire province or whatever sort of jurisdiction that they're covering. But I think that you can almost reframe rare disease and actually talk a little bit more about the science and innovation side, because the more we uncover about the human genome and make medical advancements, the more it kind of becomes about the treatments. One day, maybe in our lifetimes, all treatments will be like a rare disease treatment, right? Cell and gene therapies, some of the personalized medicine. This is the future of medicine. So I think we all need to reframe the conversation to be about the types of treatments, because they all are going to be like rare disease treatments for even common ailments in the future. So I think trying to continue that conversation and build on that conversation with policymakers is extremely important, because what's working now in terms of our, drug approval, review, reimbursement process is going to look drastically different in the future, given all the personalized medicine and advancements in research and innovation that's coming through. So maybe it's sort of changing the conversation dialogue. I kind of deviated from your original question, but I do think, there's incredible progress in Canada, and I think on the policy side, and we need to continue the momentum and continue the conversation and not take our foot on the gas in terms of continuing to drive for changes in rare disease. And the one other thing I'd add is that I don't know, this is sort of on the oncology side, but there are some really exciting announcements at a pan pan-Canadian level and at a provincial level, at least in Ontario, around access to medicines. I know, so Pan-Canadian Pharmaceutical Alliance, or PCPA, I don't know if anyone in this room is familiar with the PCPA, but they came out with a pathway to accelerate access to cancer therapies, specific cancer therapies that meet specific criteria. And in Ontario, there was also an announcement it's November now, so I can officially say last month, around accelerating access to treatments as well. So again, from a policy perspective around access to treatments, there's some really, really great policy changes that are happening, but it's specific to oncology. So I would love to see rare as sort of a next phase for that, and maybe there's an opportunity for rare to kind of be the next phase for access to treatment, both at a pan-Canadian level and also at a provincial level.
Thank you so much. And thank you. That's a beautiful segue to the conversation around access. And Stephen, I'm glad you have the mic, because that was where I was going to direct it to. In terms of, from your perspective, what are the most significant barriers that patients face in terms of whether it's diagnostic, whether it's treatment access, whether it's ongoing support, especially around the challenges of rare diseases?
Well, I think it's in all of them, unfortunately. You know, in my particular case, my ex-wife, she had a genetic disease that she didn't know. And as a child, she had terrible symptoms, and those symptoms were dismissed as being psychological until they had the right tests. And, you know, I think that many of us have those stories. It's come a long way, and the screening and diagnosis aspect of things is getting better. And the treatments are getting better. You know, for VHL, there was a super drug that was introduced now 3 years ago. And it is a super drug. It actually addresses the underlying genetic issue. So it helps, you know, address the tumors in 10 different parts of your body if you have VHL. So it's a super drug. So there's huge advancements being made. From the screening and diagnosis perspective, the national strategy addresses it. It puts money towards it. But again, it doesn't, you know, the federal government, as George said, has no jurisdiction to demand anything. So it's up to us to take the ball and ask. So I personally submitted 2 access to information requests, one at the federal level and one at the provincial level. Just asking, where did the money go at the federal? How much money was distributed? Because the bilateral agreements say that the provinces can give some of it back, but I'm not sure that they would. So how much was distributed last year? So we're going to find that out, we hope. Well, we'll see when they get it back. But I also have one at the provincial level asking, how much money did you spend on rare disease? So we'll be able to we'll be able to see. There's going to be some transparency. So from the, you know, the whole journey, you know, we can improve every aspect of the whole journey. And, you know, one of the earlier panel talked about navigation, you know, clinical navigation. And there was some psychosocial navigation after, you know, that the community groups can really support. So there is opportunity at every single stage of the journey to improve it. And we, as the citizens of this province and your province and of the country, it's up to us to really get involved, get educated, and hold our politicians, you know, accountable for the direction that's been given, the money that's been given, that we've given them, in order to make sure that our best interests are being advanced across the whole journey.
Yeah, thank you so much. And George, I wanted to follow up in terms of what are the levers in terms of provinces as well as the federal government are actually here in terms of how can we actually improve alignment?
Well, the first, and I don't know the content of the Quebec plan, but I told you earlier that I think the government likes a precedent, and if there's utility in the work that Quebec has done that's kind of, I'm going to say, cut and paste for other places, I'm pretty sure you've already done this, but to me, that's a really important leverageable element. I think that Carrie said it very well, is that there are hopeful things even beyond the national rare disease approach. And Ontario has made a strong signal around that. The Premier, I think, had a lot of pressure around that in and around the election. And the fact of the matter is, and I think I bear some responsibility for this, my fact at least, is that we have, it used to be the case that I'd be going into question period, and the thing that I'd be most rattled by is that Lisa Priest, probably at one time a colleague of the next presenter, had put had got another front page. So this is back when we had, when a lot of people were absorbing the paper newspaper, and it was like one more story about access to cancer drugs. I really actually found that as a Minister of Health, one of the hardest issues to address, in part because cancer is very high on the emotional index, which means that it punches above its weight to a certain extent. That may not sound right to your ear, and if you want to challenge me about that or talk about it more later, but I really felt after 5 years in the job, there's quite an emotional index, and some things get more attention than others. I think that this matter of what Stephen's done in sending FOI requests to those two governments is very, very powerful, especially if you do the follow-up. Because it's not very hard. Just think about the context of this in Ontario. You got 1.5 billion national. Ontario's 40% of that. That's 600 million spread over 3 years, during which the government is going to spend $300 billion. Give or take by a few billion here or there, but we're practically to $100 billion a year in health spending. You're talking about 200 million as part of that. It's not hard for me as a ministry on a first blush, in answer to Stephen's question, that give you a bunch of information that seems to validate that what the money for diagnostics went to diagnostics, etc. There's a lot of fudging capability on the part of the ministries provincially to try. I'm sure they're sending reports in to some extent to the national government. Holding them to account for these things is important. I think that advocacy, I was involved in reforms called Bill 102, which were significant reforms in pharmaceuticals, but I think there's two kind of unintended consequences of that. One is that a significant amount of the decision-making authority around what drugs are going to be covered or funded, where it used to have more political influence, I had the power as a Minister of Health to advance to my colleagues in cabinet a list of the new drugs that we should fund. And I really found that weird. I said, people would come up to me and try to pitch me on a particular drug, and it all sounded good to me. How am I going to evaluate one versus the next? So I gave those powers to a chief executive officer for the drug system, and many provinces have done that, and it's those people that are frequently keeping most of the chairs warm at the decision-making level. And I would say that those people, I'm sure their hearts are in the right place. They want the citizens to be well, but they are primarily driven by cost control. And I think that that's a reality that we have to face down, is that some of the advocacy triggers that we used to have, and I know that's going to be a subject of a next presentation, is they're diminished or they're changed somewhat. But I think the personalized medication aspect that Carrie addressed, that's an observation that I think is really something to put a pin in. And then just to say, on the diagnostics, I had the privilege of being involved in expanding newborn screening, and that ICA's done a lot of work on sickle cell, just as an example. I think that I just want to throw this out there, is that I do feel actually like the influences of AI in the primary care practice there's a certain defensiveness on the part of some doctors, the ones that didn't like the fact that the patients came in and they Googled their conditions, but actually that's just scratching the surface. We are going to have more informed patients, and at the same time, the role for AI to play kind of looking over the shoulder of the doctor, because if you imagine yourself as a doctor, you look at the conditions associated with it, they're not necessarily unique as a starting point. It can be quite a process, even if you have a very engaged primary care practitioner. And I do think that the influence of AI in kind of saying to the doc, like, those 3 symptoms could equal X, Y, don't forget about Z. I do think actually that can enhance the circumstances for appropriate diagnosis and treatment of rarer conditions.
Yeah, no, thank you so much. And on that aspect of digital health and AI, we have Ontario Health right now that's using 811, if anyone doesn't know about it, where you can actually go online to do your symptom checker. So we're seeing a lot more integration of AI helping in terms of supporting with diagnosis, especially with rare conditions. But there's always that margin of error with AI as well, right? So that's where patient voices are so key, because we know our conditions more than anybody else. We are experts within our own, diseases or whatever we're dealing with. And that kind of segues into it, because I do want to leave some time for questioning. But you talked about emotional index. I'm in health equity. I'm in health equity. I'm an equity specialist. And I wanted to kind of turn to the human dimensions of inclusion in terms of our voices and lived experiences, and valuing that within policy and how that's shaped. How can we ensure that patient voices are more meaningfully included within the access of funding and funding decisions? Because we have discussed that. And also, what are some of the key equity issues you see within rare diseases across Canada as well? So I wanted to kind of target that to everyone and then open it up for more questions. And I also want to just say, can one person also talk about, in terms of the equity considerations around cost and reimbursement as well, if you do see that as an equity issue as well?
Yeah, very, very important question, and I wish you were a panelist right now so that you could also touch on this, given this is your expertise. I feel like you should, and feel free to switch your role if you want to. So I'm going to start with the patient voice piece, and I know that you have a lot to say on this as well, given your work, but I think, so I'm going to relate back to my experience at Cancer Care Ontario 10 years ago, maybe more than that, but I was actually working at the Ontario Renal Network, and in the panel this morning you talked about the renal care system, and so just, kind of thinking about the role at Cancer Care Ontario of a patient engagement lead or coordinator or what have you, that was like relatively novel back then. Like there was a lot of emphasis on sort of building this infrastructure on the Ontario Renal Network, which at the time was in its relative infancy, and that seemed like a very novel role, and everyone was very excited about it, and we identified champions like yourselves in the community, in the renal community across Ontario, and we were it has evolved, and more than a decade later, that doesn't seem like a novel idea. Like, of course you'd have a patient engagement lead. So I think I've witnessed, and I'm sure we all have, we've witnessed the evolution of at least embedding patient perspectives in policymaking conversations. That said, I think that one thing that we can do better is patients are engaged once objectives and a goal are already set, right? There's a specific consultation pathway. I'm just thinking about Canada's Drug Agency, for example, or even the PCPA, so the Pan-Canadian Pharmaceutical Alliance, which does the negotiations on behalf of all the provinces. So there's, it's a consultation pathway once an objective, a goal has already been set. I think where we need to get is having patients, and clinicians too, because I think their voice is often underrepresented in these conversations. It needs to start with the setting of the goals and the objectives, not once they're already established. So that's kind of where I see the biggest gap in terms of policy making and decision making around reviews and reimbursement of drugs, but more sort of broadly health system policy and decision making. So really getting patient and clinician voices at the onset of determining what that shared goal and shared vision and shared objectives are. And then on maybe the equity piece specific to rare, but I think probably more broadly just health system in general, because I think it's not unique to rare diseases, although it might be exacerbated in the rare disease community. I wanted to touch on the rurality piece, which we heard come out this morning. There's a strong link, of course, between rurality and socioeconomic variables and access to care. And I think, some of the things that I want to build on coming from the panel this morning are, if you're not in Toronto, or you're not in Montreal, you're not in Ottawa, you're not in Vancouver, you have to travel a long time and spend a lot of time out of your job, your family life, travel costs, accommodation costs to just get the care that you need. And then I'm sure there's lots of follow-up visits that require the same sort of distance travel. So that right there is inequity, and I get it. We are a massive country. That's not going to change. We can't change the geography of our country. It's actually something that we're proud of. We love Canada. We love our geography and the differences, but it is something that I think could be better sort of embedded in thinking about policies around access to care, and especially the caregiver piece as well. I think that that's something that can certainly be accounted for and maybe better looked at when creating policies around access. So maybe I'll turn it over to whoever would like to.
Thank you.
Oh, goodness, no. I was waiting for you to tell me.
Okay. So I see this in two different aspects. One is the postal code lottery, and that is a very real thing still. And I also see it in the fact that when it comes to patient advocacy, we as patients need to get educated. This is a very, very complex world. There's multiple worlds that we're talking about here. And so when patients go into a project, and I've been in a few, and you're representing other patients, it really is first and foremost an education. I didn't get training when I started my first ones, and so I've been learning on the job. And I still am learning every time I start a project. It is important that we put together some training materials so that when someone steps up to say, yes, I have the time and mind space to help with a project, that they get the proper training so that they can be a educated voice and they can really assist and help where their help is needed, because there's a lot of places within the process that there's no input that's looked for. There's no change that's possible in certain parts of the system. So when you're working on a project, it is important for patient advocates to understand where they can impact and then be ready for an educated opinion, to supply an educated opinion within that particular realm. So we need to do that. The tools are there now. We learned from COVID that we can do a lot of things remotely. And so there's the opportunity to engage a lot of the rural folks. Indigenous folks, need to be part of it. There's a business case that says that we, Canada, could do a lot of great research because we have such diversity and we engage that diversity. And we're not leveraging that yet, but it has to be Canada-wide, especially when it comes to research in rare disease, because the numbers are small to start with. And if we cannot coordinate across the country, then we're losing an opportunity. And so these are a couple of the things that when it comes to advocacy, I think we need to get better educated, to supply better opinions, more informed opinions when given the opportunity. And we need to engage all communities and utilize our technology.
Yeah, absolutely. You want to say something?
Yeah, I always do. I think that the requirement for advocacy to influence public policy is fundamentally the biggest inequity that we have. And if you're actually saying to all of you that you should rise up and meet with all of the politicians X, Y, and Z, you start with rare disease. You're a fairly modest group in the grand scheme of things. And those solutions, which I've advised people around advocacy approaches, etc., a lot of the advice that I might have is not a good fit for your circumstances. The greatest advocacy experience that I saw as a Minister of Health was the Canadian Diabetes Association, which took a person with diabetes to every member of provincial parliament in support of the pump for youth. By the time it came to the legislature, they passed a private member's bill with all party support. I found the money for it naturally, and it was like, oh, it's the greatest thing since sliced bread. It's like, well, what else was I going to do? You'd frame the consensus. It was laid there on a platter. I had no choice but really to move it forward. But that's diabetes. That's, they have a patient base that's significant. To ask all of you, to ask this organization to go out and do that is quite impractical. Marrying up with others in the rare disease world obviously would be an approach that I would highly recommend. I do think that we have a significant problem in our healthcare system, which is that a lot of people get together and talk about their models of patient-centric care, or we'll call it whatever you want, but they have no patients in the mix. I went to the Ontario Family Health Team Conference a couple of weeks ago. I love my family health teams. I love the interdisciplinary care approach. I talked to dozens and dozens and dozens of people. I talked to doctors, nurse practitioners, nurses, administrators. There was no there might have been one or two. I didn't see any patients there. I think we have a real problem with that in our healthcare system. That really we haven't kicked the door down to allow more patient voice in the mix, and I think that's a really serious challenge. So asking you to confront those barriers and to advocate for this rare circumstance on its own in a province of 15 million people, in a country of 40 million people, is in itself, I think, actually highlighting the extent to which there are inequities. And the reality is, like, our healthcare system is still the squeaky wheel gets the grease to some extent. And not everybody can make the same squeaks, etc. And this really reinforms the inequity that is, I think, part and parcel of the challenge. The inequities are province to province. Within provinces, they're region to region. I wasn't here for the rurality conversation, but I'm very involved in physician recruiting for rural areas in Ontario. And the one thing I would just say about telemedicine, telehealth, and all of that, yes, invariably, if we can use that to reduce distances and people don't have to travel, particularly for access to specialized care, I'm all for it. But I'm not in favor of seeing rural Canada outsource primary care to the other end of a computer line. That is the diminishment of our rural communities. That is the closure of our local rural hospitals. Because if we can't draw physicians to practice in those places, we can't keep emergency rooms open and the like. So I'm also a little bit worried that all of the talk about telemedicine models on the primary care front are about outsourcing healthcare to suburban and urban areas at the diminishment from a health, economic, and social standpoint of those smaller communities. So a little bit of a bugaboo of mine, and try to indicate that as a particular risk for people living in rural parts of our country.
Could I just add one more thing? Yeah. When we talk about getting patients involved and getting voices involved, not every patient, not every caregiver has the time, mind, space, or interest to be involved. And so I don't want anybody to think that I'm advocating that everybody needs to do this. But I think it's important that everybody in this room, like, you've taken the time to come here, so hopefully you can answer an email or two and forward on an email or two to show support for the people that are taking some time and do have the mind, space, and interest, and I do, and David does. David's working great work out in BC, that we can show that we have numbers behind us. That is very important. So I just wanted to add that.
Yeah, no, thank you so much, because I know that oftentimes when I'm working within these spaces and representing patients in itself, the expectation for us to show up all the time is very hard. It's very challenging. Like, some days I just don't want to get out of bed. I cannot get out of bed. I cannot do certain things because of my medication. It makes me drowsy, et cetera, et cetera. So yeah, it's within the limits that you can as well. And I know that we never got to really touch on ageism and also, and racism and what that looks like within our healthcare systems in terms of inequities, et cetera. But we do know that it does also play a part in the aspect of diagnosis and how people even access care and who gets prioritized as well. So those don't go, unseen in terms of these conversations around policy. And it's important for that diversity that you all talked about, that our patient representation is also very diverse in terms of the people, because representation does matter at the end of the day as well. I know we're stealing time. We're a little bit over right now, but I don't know if we can open it for maybe 1 or 2 questions. I know that we're going to be around per se to answer any questions, but if we can be granted a little bit of time. Okay, perfect. I see a head nod. Just to answer 1 question, or if anybody has any questions. Oh, perfect. Thank you.
Thank you very much. A very, very, very interesting panel. And weaving it all through, it sounds like the access and pathway to care is money. And as we know, money is political, so it's really a political game. And I understand, George, what you were saying about 8 in 1 million people. It's not a very sexy disease, as we would call it. It doesn't get the attention that, say, cancer would or diabetes would. But you said something interesting, which was when you were a health minister and the approved drug came down from the federal government, and you said, yeah, but who's funding it? Because it's all political, perhaps that's where we should be putting our attention and sort of saying like, well, if we didn't tunnel under the 401 to build a highway, maybe we could take that money and put it, maybe save one of those 8 people. And it's very, would you agree that it's all about money?
Ooh.
No, I think a lot of it's fueled by compassion and care, but I don't pretend with people about the extent to which, as a minister of health, I spend 30 or 35% of my time justifying my department to the central agencies of the same government. And a big part of the Bill 102 reforms that I initiated was driven by the fact that when I arrived there were a couple of what we described as runaway trains. One was hospitals, and one was the drug budget, which were each at risk of trying to increase 8 to 10, 12% a year, which is, from the money standpoint, not sustainable. So I think, like you can't pretend about, like people would say, oh, well, you only need $1 million. It's just a rounding error. And I said, by the time I've had a week's worth of meetings, the rounding errors have added up to a couple of billion. Like that's part and parcel of the challenge. That's why I really think the thing that I learned the most today was from Carrie with respect to the opportunity around rare disease being part and parcel of the suite of personalized medicine. And I think I hadn't really thought about that well enough. I think that's a very keen observation. And I'll be thinking a lot more as like, how do you piggyback on that progress? Quite a bit of which is also informed from the cancer world, I think. So I think, at the end of the day, yes, like the Minister of Health in Ontario, she's got a very, very, Sylvia Jones, I was her colleague in the legislature. I have no partisan critique of her because I know how hard her job is. But at the end of the day, a huge portion of the measurement of her job from the Department of Finance, the Treasury Board, the Premier's office, and Cabinet office is she delivering her budget within what was allocated? And this is why you can see she's kind of had to put up her hand to the hospitals, as I had to at a certain point in time, is like, say, no, we don't have an unending amount of money where your budgets can increase X percent or what have you. So the money at the end of the day is a significant influence. I hate to admit that you think, well, every decision taken should be with a view towards trying to enhance the quality of health for people. The inequitable part is that there's nothing that I've seen. I think Oregon tried it or something, Andre would know better, where they kind of pulled back a bunch of spending and then they were going to reallocate it kind of on current understanding, and that fell apart rather quickly. So I could also tell you is that I didn't have the apparatus as a Minister of Health where I could say to the ministry, bring me back the 10 things that are most efficacious in the context of actually improving the lives for more people. Which seems kind of basic, right? Is like, I'm going to prioritize new spending, and how those items for prioritization of new spending get on that list is significantly influenced by advocacy capacity, which further enhances the prospect of inequity, because how are smaller groups going to fight for the time and attention to enhance the advocacy? That's why teaming up with others that have commonalities in the rare disease world is excellent. And of course, people like Durhane Wong Rieger are who ran against me in my first election in 1999. I can't get away from it. You know, luck. She's an incredible resource, suffice it to say, and I think has a lot of insight similarly about like how do we strengthen the voice. And just one more thing to say, it's like if you have the time and energy to go and see your member of provincial parliament, MLA, MN, whatever province, national, like different monikers in different places. I was trying to be clever, got trapped in it. The thing about it is that a politician has, I always say, like a politician has, is best if they operate with a certain degree of paranoia, which is informed by the fact that they are obligated and pushed to work within a set line. Boundaries cause many problems. I developed local health integration networks. Anybody want to talk to me about how you figure out where boundaries ought to go? But the thing about it is that all politics is local, and don't ever forget about it. Your member of parliament works for you, and if you have the time and energy to go and put this rare disease on their radar screen, absolutely take advantage of it. And before you know it, the Minister of Health in caucus is getting questions from 3 or 4 MPPs who said, I had a really, really fascinating presentation about this rare disease. You know, like that's another example of how you can build a bit of momentum on the advocacy approach. And sometimes it just takes luck. And this is the last thing I'll say is like, trace back to the people of privilege, position of power that have a personal attachment to a rare disease or to this one, and you have a much stronger like sometimes it just takes luck. It's like, why is that guy so interested in this issue? It's like, well, his kid is this or that. Like that personal aspect of it should also, from the standpoint of strategic prioritization of advocacy resources, is if you can sometimes find a link there that you can have an individual that's willing to put their personal power and energy behind elevation of the issue. So that's another approach that I would really suggest people look for.
Perfect. Thank you so much to you all for such a rich discussion. And it's clear that the progress in terms of rare disease care in Canada requires both policy precision, but as well as human connection is the most important. So something that this summit also continues to embody. So I just want to thank the organizers and Anne-Marie yourself. Thank you for inviting us and for this conversation. And we will be lingering around, so you can definitely ask us questions. Maybe not me so much, but the experts on the panel in terms of any other questions around policy and advocacy. So thank you for having us. Take care.
Thank you.